Good morning and good evening, all my friends in the ICC. I'm so honored to invite our special speaker, Professor Dipesh Rao, for the 121 ICC webinar today. I am Dr. P.Y. Cho. Today, Junior is absent for his support the hockey teams in Winter Olympics, so he want to take a leave to support his favorite team to win the gold medal. So I will be the one be with you, all my friend here. Dr. Dipesh Rao is a dual qualified MBBS and MDS and the international board certified maxillofacial surgeon. Currently a consultant at the Smile Trend Lab Leadership Center in Bangalore. His extensive training include fellowships in cleft and craniofacial surgery in Bangalore, Melbourne, and Oxford. Dr. Rao's clinical expertise spanned the spectrum of cleft deformities, transcranial procedures for cranial synostosis, and orthodontic surgery. Notably, he is among the few surgeons in India utilizing in-house the virtual surgical planning for precise aesthetic and functional outcomes. An active researcher and associate editor of the Journal of Maxillofacial and Oral Surgery, and he served as the faculty for AOCMF and SORG SOC India, and he is a member of the IAOMS Educational Board. Besides, he invited his partners, Professor Dr. Abner, the PhD. Dr. Abner is the speech language pathologist at the Smile Trend Lab Leadership Center, Bangalore. With over a decade of expertise, she specialized in the assessment and the management of the resonance disorder, velopharyngeal dysfunction, and compensatory articulations. A key member of the interdisciplinary cleft team, Dr. Abner is dedicated to evidence-based practice and professional mentorship through the Mentoring Alliance for Global Speech, MAGS. Her academic contributions include numerous peer-reviewed publications and leadership roles in the major scientific committees, include the International Cleft Congress and the India Society of Cleft Lip and Palate Craniofacial Anomalies. So we are so honored to have them both to present the topic today. Our special topic today is the deeper understanding of the velopharyngeal dysfunction correction. So, by the way, we invite three very important experts in this field. The first one is Professor Fayaz from Lahore, Pakistan. And Professor Fayaz is a well-known the professors and did numerous missions, especially in the Middle East and even in the Europe, Africa, and a lot of areas. The second, the panelist is Professor Hikosaka. Professor Hikosaka just finished a very wonderful event in Kyoto Club 2025. So let's welcome Professor Hikosaka too. And the last one is our chief in Asan Medical University, Professor Tasu Oh. So Professor Oh, thank you for your coming and to be attending for this great comment from your side. And cannot wait. So let's welcome Dr. Dipesh first. Okay, Dipesh, please. Thank you.
Thank you so much. Is my screen visible?
Yes, it's good.
Yes, right. Thank you for the entire group for the invitation. I think I've learned so much from the ICC webinars myself. it is a real honor to be now presenting at the webinar and to have such esteemed panelists. I'm sure we will have very good discussion at the end. And that's the probable goal of this webinar as well. I think it would be fitting to say that if I were to do this talk alone, it would be just the understanding of VPD correction. The fact that I now have our speech and language pathologist with us makes this part a little more intricate and detailed, because she is the one who kind of gives us the non-biased opinion for all our speech and language outcomes, and also gives a very accurate measurement of what we think would be helpful to do our speech corrective surgeries. So in the next few slides, I will try to highlight where how we have come across the burden of VPD and what is our mechanism or an algorithm to correct it. We are from Bangalore, which is in the southern part of India. This is the hospital, and this is our team. We are one of the largest comprehensive cleft care team in the country, and we are fortunate to be working in a multidisciplinary setup where all the outpatients are next to each other. So which means if we have any concerns, we just hop into their outpatient and the concerns are addressed immediately. And that makes it much, much more easier to have what we would think is a live MDT kind of a setup. I think we all know the burden of velopharyngeal dysfunction, especially after cleft palate care, ranges from 4 to 33%. In other words, there are a lot more children even to date who need cleft palate velopharyngeal dysfunction correction. And this burden will remains unsolved if we do not kind of have a sort of algorithm to correct this kind of presentation. This is something that I'm sure all speech and language pathologists know, and this is the universal parameters, which is still remains the gold standard to assess a patient with cleft palate and to identify VPD. However, at this point, I would ask Aparna to explain this triage that we utilize for our patients. Aparna?
Yeah. Yes, thank you, Dipesh. So, perceptual speech assessment is the gold standard for diagnosing VPD. Of course, now we need instrumental assessment to validate it and make plans. But a well-trained ear will be able to identify the instances of VPD, even if it is mild, and we should be able to do that because instrumental, if we are not carefully doing a perceptual assessment, we could make errors with judgment on the instrumental assessment, the imaging which we take from the instrumental assessment. So in perceptual speech assessment, as Dipesh mentioned, we use Henningsen's protocol. So there are various parameters. We look into hypernasality, nasal air emission, a lot of errors which can be learned and which can be obligatory because of the velopharyngeal dysfunction. So the learned errors are usually corrected with speech therapy. You could have condition where you can have a velopharyngeal dysfunction plus learned error. In those cases, we still prefer to do some amount of therapy and make sure that the whatever we gonna see in the imaging is actual reflection of the perceptual speech parameters. And if there is a velopharyngeal dysfunction, you are directly going into an instrumental assessment and getting an imaging done to make sure that, so you could do an instrumental in terms of direct and indirect, but we always have to substantiate your perceptual finding with a direct imaging, which is either a nasal endoscopy or a video fluoroscopy.
And in our center, we have the access to all three instrumental assessments: the lateral video fluoroscopy, the nasal endoscopy, and the MRI. Having said that, over the years, we have always been probably more comfortable with the lateral video fluoroscopy. And I think there is a particular reason for that. That is, it can be done on a younger child first, because if we want to pick up the velopharyngeal dysfunction, it is much more easier to do a lateral video fluoroscopy, then introduce a nasal endoscope and check the port, or getting an MRI compliance, especially in children at the age of 4 to 5 years of age. So that's why, to pick it up early, we've kind of always preferred the lateral video fluoroscope. And having said that, it is also the only way that we can have what has already been described, a validated measure of checking the velar function using the closure ratio. I'm sure most people in this audience already are aware of the closure ratio. For residents and those who are not tuned, if you have the palate hanging and this is the posterior pharyngeal wall, this becomes the resting gap. And when the palate is excurting, the full excursion of the palate, that is where the excursion ends, that becomes the velar gap. In other words, if the velar excursion is very good, the resting gap and the velar excursion should be equal. That means the closure ratio should be 1. That means the velum is completely excurting and going and touching the posterior pharyngeal wall. If it is not moving at all, if the palate is not moving at all, the velar gap and the resting gap are similar, the gaps are similar, so they become a large gap and 0, no closure ratio. So the velum should excurt the entire extent of the resting gap. That is a good closure ratio. If it doesn't, then it is 0. So in between that, if you look at the scale, that is where you get the closure ratio. Now, our preference has been to utilize the closure ratio, but when we started looking at it more closely, we realized that what are the management options? Can we actually make these management options based on the closure ratio? If you want to move the palate, you need to make sure that there is a procedure in the palate, which can be a dynamic procedure. In other words, the most commonly used procedures are redoing the palatoplasty, which means probably the muscle repair might not have stayed in the place. There would have been a relapse of the muscle position, or it would have been the case is transferred from another unit where the muscle dissection was not done at all. So you may be able to reposition the muscle by doing a conventional muscle repair, whether it is somalite or somalite-like repositioning, or do the Furlow's double opposing Z-plasty, which means again the emphasis is putting the muscle in the posterior third of the soft palate, or the interpositional buccal myomucosal flap. So these are the ways I think the management of the soft palate can be done. If there is a static approach, and I think more and more people are going away from pure pharyngeal procedures, the large pharyngeal flaps, because of the burden of sleep apnea in these patients when they grow up, and the only ones which have survived or sustained are the small, narrow suspension pharyngoplasties, which add on value to the velum and probably act like as a pull towards the posterior pharyngeal wall. And in some cases where there is a recalcitrant VPI, augmentation of the pharyngeal wall using fat or other mechanisms is also being postulated. When we looked at our own cases, and this is something that I personally feel that one of our major contributions to velopharyngeal management, which has been published in the 2021 version of Cleft Palate Craniofacial Journal, wherein we gave that the Furlow's palatoplasty alone was able to sort out most of our velopharyngeal dysfunction patients. In other words, a procedure which is allowing a repositioning of the muscles in posterior dimension was able to look after a vast majority of our patients. However, in that we had, by serendipity, a formula that came out with the statistician to actually identify in which patients, if we do a Furlow's, we will be able to get a good result. Now, if you have the closure ratio, that is the pre-operative closure ratio, and you want to predict the post-operative closure ratio, in other words, you have a gap, let's assume it is 0.4, 0.5, and you want to know that if I will get 1, we can use this formula to get a prediction of the closure ratio. The advantage of this formula is that it takes into account the clinical parameters assessed during speech. That means if a child has moderate hypernasality, you can deduct some score. So this 0.43 is the constant. You deduct 0.11, from if the patient has moderate hypernasality. If the patient has severe hypernasality, you deduct 0.14, add 0.05, which is another constant for the nasal air emission, if the nasal air emission is present, and add another 0.82. Now, the genesis of this complex formula was probably from a regression model which the statistician was able to identify. But what it allowed us to do was, by utilizing this same formula, we were able to predict patients who are getting close to 1 ratio, which then allowed us to come with a small algorithm of our own. And now we have validated and back tested this algorithm, that if we are getting 0.8 as a prediction and more, that means closer to 1, Furlow's palatoplasty alone is sufficient in those patients. If the predicted closure ratio is less than 0.8, which means now the burden is slightly more, just repositioning the muscle may not be alone. And this is the conventional Furlow's palatoplasty that we do. We are not doing the hybrid Furlow's palatoplasty like mentioned in many units. So in this procedure, what we realized was that if the predicted closure ratio is less than 0.8, there were some dilemmas that we had, whether to do a Furlow's with superior base pharyngeal flap or a Furlow's with a buccal myomucosal flap with or without a pharyngeal flap. And we will then come up with some clinical scenarios where we were able to establish that data as well. So here are some case examples that Aparna will go through to showcase how our algorithm was allowing us to get to our desired outcome.
Yeah. This is a 5-year-old who reported with hypernasality and obligatory speech errors. Of course, he also had some compensatory errors. And after a period of trial therapy, we did a video fluoroscopy to confirm the degree of or the severity of VPD. Dipesh, can you play the sample? Volume. Tata. Pipi. Kaka. Kiki. Sasa. Sisi. So you could clearly perceive the hypernasality there. Okay. So he also had a nasal air emission. The closure rate, previous slide. The pre-operative closure ratio was 0.6 and the predicted closure ratio based on using the formula was 0.86. So this 0.8, so as Dipesh mentioned in the previous slide, 0.8 is the criteria where we decide 0.8 and above, we do a Furlow's palatoplasty. So as planned, Furlow's palatoplasty was done for this patient. Next slide. Can we play the video? 2, 3, 4, 5, 6, 7, 8, 9, 10. So you could see that the velum now completely closes against the posterior pharyngeal wall. However, it's not a tight closure. This might improve with therapy as well. But this patient was discharged with normal speech understandability and mild speech acceptability. That's because he had some degree of nasal with the normal nasality. So which was a successful repair for a Furlow's palatoplasty. So this is a case, 9-year-old female, and can we play the video? 62, 63, 64, 65, 66, 67, 68, 69, 70. So in this video, again, the nasality is well perceived. You could see how the velum is moving. The velum is elevating, but you can see the gap between the velum and the posterior pharyngeal wall. You could also find there is a passivance ridge coming forward, as a compensation. This kid was speaking well in terms of trying to speak well, but she had severe hypernasality. And closure ratio, operative was 0.5, predicted was only 0.7. So 0.8 is our cutoff. So we had to do some other procedure. So here, a Furlow's C-plasty plus pharyngeal plasty is done for this child. We can play the video.
Count from 60 to 70, 61, 62, 63, 64, 65, 66, 67, 68, 69, 70.
So it's very clear. Okay. I mean, I'm sure audience can clearly make out it's a normal speech and discharged without much speech therapy as well, because her problem was only that she had severe hypernasality. This is a third case where we see, so unlike the previous two cases, we were seeing the velum elevating, velum moving. So here you see a difference. So nasality is clearly perceived. There was nasilar emission as well. However, the characteristics of the velum is not elevated. So it's hardly any movement, a flickering movement. And the pre-operative closure ratio is 0.1. So predicted is 0.45. So definitely not a case of furloughs. May or may not be a case of a superior base pharyngeal flap. However, in this case, we have done a buccal myomucosal flap. And next slide. Completely closing against the posterior pharyngeal wall. She has some nasal grimaces left over since her recent case, and her speech is normal now. And you can also see the velum started moving. So probably it would be, maybe Dipesh can add on to that. Probably it would have been a very scarred palate when a buccal flap was put up and then the scar is released. The velum also started elevating. This is a fourth patient. Here, when you see the video fluoroscopy, can you play the fluoroscopy? No, video fluoroscopy. Fairly good gap there. Velum is moving. In such cases where you see the velum moves and then there is a gap, you find that the speech findings will be pretty much okay. So in this patient's speech,
61, 62, 63, 64, 65, 66, 67, 68, 69, 70. 91 to 100. 91, 92, 90.
So unlike the previous patients, you're not hearing a hypernasal. You're not really hearing it as speaking through the nose, but then you could hear a nasalar emission. So in such cases, again, the closure ratio is 0.5 only. However, the nasality is mild. There's only nasalar emission, and the predicted closure ratio is 0.8. So that is the beauty of this formula. When the speech is better, it might give a better prediction, and we might not go into a more invasive or more aggressive procedure. We could still be doing a furloughs based on the speech findings and the velar. So it's all reflecting the velar excursion. So the furloughs palatoplasty was done. And we have a long-term outcome of this patient. So this is his recent one. He is an adult now, and it's completely closing. You could see the velum touching the posterior pharyngeal wall, and that's his speech.
ಸಮುದ್ರ ಸುತ್ತಿದಳು.
ಪಾಪು ಪಟ್ಟ ಪಟ್ಟಿಸಿದ.
ಪಾಪು ಪಟ್ಟ ಪಟ್ಟಿಸಿದ.
ಕೆರೆಯಲ್ಲಿ ಕಪ್ಪು ಕಲ್ಲಿತ್ತು.
ಕೆರೆಯಲ್ಲಿ ಕಪ್ಪು ಕಲ್ಲಿತ್ತು.
ಬಾಲು ಬಾವಿಯ ಬಲಿ ಬಿತ್ತು.
ಬಾಲು.
It's normal. You could perceive there's no nasal emission or nasality. Like nasal emission was there in the previous video, but even that is not perceived now. Next slide. These are cases where it's very tricky to take a decision. So this is a pre-operative finding of a child who has nasal emission and nasality, who did not respond to therapy. Even though you do intensive therapy, you still find that, and you find that in the video fluoroscopy, there is a touch closure, there's closure. However, if you see the velum, you can see the end of the velum touching the posterior pharyngeal wall, and there is a definite compensation by the posterior pharyngeal wall. So when on a connected speech, you have to really speak fast and can't maintain a good pressure, not really vigilant on doing it. then you still have nasal emission and hypernasality. So in such cases, again, a furless palatoplasty is an option and it gives wonderful results. So it will just clear off that whatever residual nasality emission, which might be mild, but it calls attention. A child speaks over the mic, you can hear a nasal emission or mild nasality. So such cases, borderline cases, again, furless palatoplasty would be the opted method. Yeah.
So I guess with these case samples, before I start explaining, how do we sometimes have to clinically correlate? And this is the biggest challenge, because we get the instrumental assessment in most cases, and we know based on the formula that we have to choose between a furless palatoplasty versus a furless palatoplasty or with the pharyngeal flap, or a buccal myomucosal with or without a pharyngeal flap. Now, there are a couple of things that I think we also need to highlight, is that in most cases, there would be a chance that all these patients have either had no muscle repair from the previous surgeries where they were done elsewhere, or in our center, we always do the muscle dissection and repositioning. So it is not, the primary repair itself is not a furlough. However, in patients who have received a furlough repair, we have gone ahead and done another furlough and found that it improves the speech in those patients as well. But the dilemma still remains that how do you clinically correlate the algorithm that we are proposing to patients with short palate, where the adenoid pads are visible and you get a very large predictive closure ratio, which means in those patients, you're going to suggest a furloughs with a pharyngeal flap. And in this patient, the base of the pharyngeal flap is still going to be away from the soft palate. So is that a patient that we would be able to fit into the algorithm? Probably not. And these are the patients where our mind will say that we need to probably consider buccal myomucosal flap, because if the base of the pharyngeal flap is at the adenoid levels and the entire adenoid is visible, that means in a short palate, and I will show you a case of that, it might be hard to get the pharyngeal flap with the furloughs and utilize that. Also the scarred palate. Now the scarring of the palate is also very subjective. What I may feel as scarred palate, Professor Om, I think it is not as scarred as it is. And it is something that is very, very different because of the subjective nature of our evaluation. And when we touch it, we feel it is quite cardboard-like and doesn't move. And that's probably when we realize that the quality of the tissue is not going to be good enough for our furloughs movement. Even if we put the release incision, we may not be able to get the furloughs flap. And this would also probably prompt us to use an augmentation flap for the velar area itself, like a buccal myomucosal flap. And of course, if there is a significant pharyngeal compensatory mechanism, that kind of makes us believe that it is easier to have a pharyngeal flap along with that pharyngeal compensation in patients who have very poor velar movement, and that's the clinical picture that we look at. So here's a patient who, when you look at, and has a good amount of length, very minimal scarring at the soft palate junction, maybe a couple of small pinpoint fistulas. This is an easier case to predict doing a furloughs palatoplasty and achieve the result that we look at in our cohort of patients. However, if we have to describe the short palate, and this is something that we are now trying to get, that if we measure take a line from the tuberosity, from one end of the tuberosity to the other end of the tuberosity, and measure the longest part from that area to the end of the base of the uvula, not considering the uvula as a part of the soft palate. And if it is less than 15 millimeters, then definitely the palate is short and we need to augment it utilizing a buccal myomucosal flap. Now, whether this is a validated number, whether it is 15 millimeters, 10 millimeters, it's still debatable, because it would require a very large cohort to actually say what is short. Remember, the furloughs main caveat was a functional palate is what is important for speech. The length of the palate does not matter. And that's one of the reasons why we also still strongly rely on what we look at on the lateral video fluoroscopy. If you have just thick bands at the hard palate, but the entire adenoid pad's visible, again, here is a situation where we might shift away from the algorithm and choose a buccal myomucosal flap to interpose between the hard and soft palate, and thus break the soft palate, hard palate bands. And that was what we did in that case, where Aparna was saying that it was completely static. The velum did not look like it was moving. But when we did the interpositional flap, the scars had broken down because of the interpositioning of the buccal flap. The velum actually sat posteriorly, much more posteriorly than what it was. And also now, so in all the cases of buccinator myomucosal flap as well, we are kind of trying to cinch the lateral, the levator muscles together so that we get a nice sling of the levator muscles in the velum as well. So it is not just interposing the buccal myomucosal flap, it is also trying to cinch the levator. And with this, I think what is the important part of our entire conversation or entire lecture was the fact that the formula works in almost all the situations, except in, of course, these situations where you've had 2 or 3 procedures in the past, wherein despite having 2-3 surgeries in another center, the patient now presents to you as if the cleft palate was never repaired. So in that case, what we have started doing is adopting the ACRP principle for the primary repair. Basically, look at this as a primary cleft palate and do what Robert Mann would do for a primary cleft palate, do this. And these are also now responding to the buccal myomucosal repositioning of the velum as well. So what tends to happen is the velum is still in the right position and they've been speaking much better after the surgery. Another example where 3 surgeries were done and the 4th one was a buccal myomucosal done elsewhere again, and despite this kind of a presentation, we just took this buccal myomucosal flap as a primary flap, repositioned it posteriorly, and this is the outcome. And again, this patient has responded very well to the speech from its severe hypernasality to now mild hypernasality. So these are the challenging cases where probably sometimes we cannot stick to the algorithm, but the algorithm has served its purpose in most of our cases. We are happy to have the discussion going so that we can put more light on this. Thank you so much.
Thank you, Dr. Dipesh, for your sharing so difficult cases with your speech pathologist, Dr. Dabana. I would like to invite all our 3 invited panelists to give their great comment according to your difficult cases. The first one, I would like to invite Professor Fayyaz. Professor Fayyaz, please provide your great comment for Dr. Dipesh. Thank you very much.
Thank you very much, Dipesh Rao. Very good presentation. And also for Aparna, I'm sure I'm pronouncing it good. Very good presentation, very good explanation. My comment would be that so far we have not been able to classify the short palates. Short palate may be from different reasons, many different reasons. And maybe I have operated, or you have operated, or somebody else has operated. So I think we as a group, we should work on how we can classify the short palate, and then according to that classification, we can make an algorithm which procedure should be done. So far, we have not done any buccinator myomucosal flap in primary cases. However, our great friend Dr. Bobman, he usually recommends that it should be done even in primary cases. I usually reserve these in difficult, complicated cases. So my question would be to the Dipesh is, so when you do a pharyngeal flap, do you still dissect the muscle and suture the muscle together at the base of pharyngeal flap, or you will just go and do the pharyngeal flap and then close the palate?
Thank you, sir. I will answer the question first. First I'll answer the comments and then I'll answer the question. I completely agree that we need a consensus on what is a short palate, and I think that basic measurement that we are trying to follow will allow us to have some consensus, because if we take a line from the tuberosity, at least that would be common for all patients. The second point which you mentioned, that reservation for using buccal myomucosal flap for primary, Bob Mann has come to our unit twice and demonstrated the entire workhorse of utilizing the primary the buccal flaps for primary repair, and we're very impressed with his results. Like you mentioned, we still are a little conservative and would like to keep some backup just in case we need it, and that's one of the reasons why we've not adopted it in our primary repairs, but we have used it in our secondary repairs. Now, coming to your question, whether the pharyngeal flap, where do we sew it? So in our furloughs, we don't do the hybrid furloughs like described by Mukund Reddy, and what I think now is also being followed in Taiwan and some other parts. We do the conventional furlough and the suspension pharyngoplasty. So it's not as wide as what Philip Chen has described. It is slightly narrower than that. So you can put 2 ports of nasal tube on each side, and that will allow you to know the width of the pharyngeal flap. It is sewed to the nasal layer alone without the muscle in it. So the muscle is sewed above because of the way the flaps reorganize.
So then another question would be, what is the maximum width of the posterior pharyngeal wall you would like to incorporate in the pharyngeal flap? So because many of our friends, they are very afraid if you do the pharyngeal flap, patient will develop obstructive sleep apnea. So what is your protocol?
Correct. So that is one of the reasons why we use a narrow suspension pharyngeal flap, because again, the fear of sleep apnea has been instilled amongst us all. And I don't think there is a proper cohort of looking at patients who have received pharyngeal flaps for cleft palate repair and what is their long-term sleep apnea concern. That has not been described quite lucidly yet in the literature. So our maximum width, we can go up to 2/3, like described by Philip Chen in his article, that the Chen's pharyngoplasty. But our preference is using the suspension pharyngoplasty as described by Mukund Reddy, which is a slightly narrower flap.
Thank you very much.
Thank you, sir.
Thank you, Professor Fayaz, for your great comment. And the next, I would like to invite Professor Hikosaka. Professor Hikosaka, thank you for your comment here. Thank you.
So, Dipesh, thank you for your lecture. I was quite impressed by the thickness and improvement in the movement of the velum after the secondary procedure. My question is about the dimension of the suspension pharyngeal flap. Could you provide the exact dimension of the flap, the width of the flap?
Yeah, so the width of the flap, we are trying to keep the same concept twice, not more than 2 times the width. So that is the dimension. And the width is approximately 2 centimeters and not more, because we need to keep 2 nasopharyngeal tubes on either side of the flap. So that is kind of allows us to have a ballpark number. And when we look at the pharyngeal wall, we try to take the center meat of it without trying to encroach too much, because the wider it becomes, then like we were discussing with Professor Fayaz, the risk for apnea is what we are worried about.
Thank you. May I ask you one more question?
Yes.
My question is about the patients who had primary parallel palatoplasty in their primary surgery. You've mentioned that when they have a VPD, you would choose parallel palatoplasty again when the predicted closure ratio is equal to or more than 0.8. Now, what would you find when you open up the palate? Would you see the muscles going like in the longitudinal direction, or is it already in the transverse direction?
Very good question. So what we have noticed is, more than the muscle orientation, it is probably the scarring, the tethering that happens at the hard and soft palate that is preventing the previous furlough or the previous muscle repair to work. So when we do a furlough, and this is something that we realize that the Z-plasty of the furlough kind of works more in the favor of breaking the scar and putting it back into place, and of course repositioning the muscle. When we look at the muscle per se, it is very and I think it is also a part of the evolutionary process that now we are much more tuned to the idea of cutting anterior to the eustachian tube, making sure that the entire levator is recruited in our repositioning, and that would have been the difference between the previous furloughs and now. But that's the only thing that I think. But mainly, if we have to look at it closely, the main factor would be breakage of the scar that is there between the hard and soft palate.
Thank you. Thank you very much.
Thank you, Professor Hikosaka's comment, and thank you, the Kyoto, Lab 2025, for your very hospitality for all of us. Thank you. ありがとうございます。And the next one is the Professor O from Asan Medical Center. Professor O, please.
Yes. Very beautiful presentation. I'm very impressed that because when we do the follow for the cleft palate patient, when the patient has a BPD, it is very difficult. Sometimes it is very difficult to decide that we should do double opposing G-plasty enough, or we should do the posterior pharyngeal flap or any other procedure. So, and in advance, I want to introduce I worked in Asan Medical Center, and I want to introduce our institution protocol for managing the BPD patient. If the patient has a BPD, BPI, so the first choice is the double opposing G-plasty. But if the patient has syndromes like the Kabuki syndrome or Craniofacial syndrome, we cannot expect any movement, even though we lengthen the soft palate. So we skip the lengthening procedure. So we further do the first choice for that patient is the posterior pharyngeal flap. So, and then even after double opposing G-plasty, if the patient still has the BPD, we consider the redo double opposing G-plasty in some patient. It means that the second time double opposing G-plasty. And in some patient, if we do not expect or we cannot expect any improvement with the second double opposing G-plasty, we do the posterior pharyngeal flap. So, but I think that we also have our hyponasality grade. The scale is the 7th grade, but sometimes the moderate hyponasality group is very difficult to consider the surgery. So if the patient has the very scarce soft palate, and if we can get any improvement with the surgery, with the scar relief, so we do the double opposing G-plasty. But I think that the problem of the double opposing G-plasty is that we cannot borrow or get any new tissue. So we should arrange the tissue with its own tissue. So sometimes the most dangerous, the difficult situation is that even after transfer of the double opposing G-plasty, if there is a scar, especially the horizontal scar after repair, I think that it is worse than repair. So we should prevent the horizontal scar after double opposing G. So in our institution, to prevent that kind of tissue deficiency induced horizontal scar, we add buccal pap flap. So buccal pap flap. So it is published in the maybe ACPA, the CPCJ journal. So we can prevent the horizontal tissue deficiency and after the scarring. So I think that it will be. I also asked what is your protocol? You do the double opposing G plasty, you do only double opposing G, or you add some tissue from the buccal pad or the buccal tissue. And the second question is that I think that it is the most typical patient in our cleft clinics is that the patient without cleft palate. So what is if you have any opportunity or experience with the patients, sometimes I do 3 cases of the posterior pharyngeal flap for the patient, so I can get, fortunately, some improvement of the hypernasality. So I want to ask if you have any interest or experience with the patient, or I want to ask any panelists like the Dr. Fayaz or Dr. Ikosaka or Professor Runjoro or Professor Peng Yunjo, the most difficult case.
Sure.
Thank you.
I'll answer.
Congratulations. Thank you.
Thank you, Prof. I'll answer both these questions. And the first being about the Furlow's palatoplasty. I think after we've started adopting our formula strictly, because it gives us, the formula incorporates speech parameters, it allows us to know that the patient may have a supple palate because of which the patient is speaking well. And that's where, when we are doing the furloughs, we are not encountering as many problems as we used to encounter before, which of a scarred palate, which would be non-respondent to movement, and then because of the way the scarring is, the furloughs doesn't move, and then we have a horizontal scar. And you're very right that in those patients where we have attempted furloughs palatoplasty, where the palate itself, the soft palate tissue itself, is not allowing us to rearrange the tissues well, we use the buccal fat pad too, sometimes, to kind of not leave a very bad tensioned scar, which is anyway going to break down. The mucosal edge is going to break down, and you get a horizontal scar eventually. So your furloughs will not work. So in those cases, to prevent that, we have used the buccal fat pad. Very rarely, we've also used a single buccal flap for the mucosal closure. But I think after the adoption of the formula, it is because of the way the formula incorporates speech parameters, it is allowing us to know that the palate is slightly more supple than otherwise it would be. Of course, this is just a guess. That is why we are kind of being able to do furloughs in most of our patients where the predictive score is more than 0.8 without encountering much problem. To answer the second part, in non-cleft VPI patients, again, we have tested the same formula, and we have gotten our predictive closure ratio beyond 0.8, which means it is less than 0.8, which means they have 0.3, 0.4, and we have done a furloughs with a pharyngeal flap. We have a cohort of 3 cases now, I think 2, and the third one, so 3 cases. The third one we haven't followed up yet. The 2 cases that we have followed up, we have the pre-operative, post-operative MRI data as well to see, because we looked at the MRI and we found that the muscles were hypertrophic, which means they were almost agenetic muscle, very spindle-like muscle, which did not kind of function well. And in one, I think it was a denervation issue where the muscle looked all right, but there was no movement at all. It was just a static floppy palate. And characteristically, both these patients had long palate. The palate is long, but it is not functioning. So it was again like classically described. It is not the length of the palate that is important. It is the movement of the palate. And that's one of the reasons why I think in such palates, adding a pharyngeal flap allows the suspension, so that it can pull that pharyngeal, the velum towards the pharyngeal wall. And that's one of the reasons why utilizing the formula and looking at the picture, we incorporated the pharyngeal flap in both these patients along with the furloughs. The furloughs was only an attempt to rearrange the muscle more posteriorly, but one muscle was almost, like I mentioned, agenetic. The other muscle was there but did not function or did not fire. So yes, and MRI gave us very good value because looking at the MRI, dynamic MRIs, we were able to assess why the patients had VPI despite no clefting. Thank you, Prof.
Thank you, Dipesh. And for the second question from Professor O want to share and to asking all the panelists your comment. Maybe Professor Low, would you like to give your experience for Professor Low's second questions? Yes, please.
Yeah, I think for the Dr. O's question regarding the non-CREP patient, right? Non-CREP patient who has the VPI. I think in our practice, I mainly use the closure ratio as a indicator for selecting the procedure. We use closure ratio 0.7 or more for double plasty, and closure ratio less than that, we use the pharyngeal flap. So this criteria apply to all kind of patients, either after palate repair or non-CREP or for other reason. So I think it's quite simple in my practice. Yeah.
Thank you, Professor Low. And then we come back for Professor Hikosaka about your comment for this question. Thank you.
Thank you. The protocol in our center is much more simpler. We always do pharyngeal flap for all the patients. That's our first choice because we're afraid that doing follow repalatoplasty, and if we fail, then we have to come back on the pharyngeal flap. So I think most of the patients can achieve good enough pharyngeal function after single pharyngeal flap. So that's the reason why we always do a pharyngeal flap. I know there may be some controversies, but that's our way. Thank you.
Thank you, Professor Hikosaka. And the final, I would like to invite Professor Fayaz. Yes, Professor. Yes.
I think when we get a patient who does not have any cleft palate, but the speech is still hypernasal, or there's more nasal air emission, or the speech is hypernasal, so we have to take the history. I still remember an incident, and this incident happened in India. A patient came to a cleft mission. His speech was almost as the palate was very short, and the surgeon and the speech pathologist, they tried to work out what is the problem. They could not find any abnormality. After 2 or 3 days, the patient brought his mother, and his mother had cleft palate, and he was mimicking the voice of his mother. So we should also take the history, whether do you have any cleft patient in your family, in your sibling, in your surrounding. So that boy was used to learn the voice of the mother as the normal voice, as the normal speech. And then our protocol, we usually go for a pharyngeal flap. In such cases, probably we have done 2 or 3 patients. But when we do the pharyngeal flap, we try to whatever the muscles are available, we dissect the muscle, and we would like to suture the muscle together at the base of the pharyngeal flap. So we would like to provide some good movement or whatever movements are possible at the base of pharyngeal flap so that the closure ratio becomes positive. And then we do not go more than 60% of the width of the posterior pharyngeal wall to be incorporated in the pharyngeal flap. We want to keep 20% on both sides for breathing. That's it.
Yeah, thank you. Thank you, Professor Fayaz. The history is quite important. Yeah, and for Professor O's questions, I follow Professor Low's protocol. Non-CLEP patients with the BPI, yes, history is important, age is important, and according to anatomical structure defect, and with the fluoroscopy and nasopharyngoscopic the finding, we tried using depending on the portal closures rate, yeah, furlough or pharyngeal flap. Okay, and finally, I would like to invite Professor Low to give your personal comment for this Dipesh presentation. Thank you.
Professor Dipesh Rao, thank you very much for your presentation. I think for patient with varipharyngeal insufficiency after cleft palate repair, I think each surgeon or center have their preference in order to improve the varipharyngeal insufficiency. In our practice, we try to improve the hypernasality by narrowing the VP port. We also are very careful to not to create airway obstruction, especially the obstructive sleep apnea. I think this will be our very careful monitoring when we select a procedure. So whenever we choose pharyngeal flap for a closure ratio 0.7 or lower, then we will be telling the patient parents that the patient will experience snoring or narrow airway or even foreign body sensation in the posterior pharyngeal wall. I think that's why we very carefully choose the procedure, especially the pharyngeal flap. Our previous success rate for the double opposing Z plasty for the VPI is about 80%. But now recently we use buccal fat to fill the dead space in the anterior portion of the soft palate, and then the success rate significantly improved. And I would quite recommend it. This practice, and this is very helpful. Now going back to selection of the VPI procedure, as I mentioned that each center or surgeon had their preference. I think you could choose whatever you feel that it will work for you. In my hand, I think pharyngeal flap is very helpful. Sphincter pharyngoplasty is not very helpful in my practice. However, I do believe that for many other surgeons, sphincter pharyngoplasty is a good procedure for your choice. So I think if you feel that it is good for you, I think it's okay in your practice. Anyway, thank you very, very much, Dr. Dipesh, for your presentation. Very nice. Thank you.
Thank you, Prof. Thank you for your kind words.
Yeah, thank you. Now is the QA sessions. We have some friend refer some of the questions for Dipesh about your teams, the case sharing. The first one is that how about your long-term result with a pharyngeal flap in the speech evaluation and maxillary growth, the further the development. So what is your experience? Thank you.
So from our center point of view, we are a 20-year-old center, which means the patients we did 20 years ago are now in the current lot for Leaford osteotomy. And if we have to look at the impact of pharyngeal flap and its growth restrictions, that data will require another few years. We don't have that data to kind of comment on for the patients who have received pharyngeal flap by us and what is the growth impact. I think they are still slightly younger. The initial growth response at around 12 years of age has not been any different as such. But that is just anecdotal because we will have to look at it and completely follow it up till the skeletal maturity to give that data.
Okay, thank you. And I continue very similar questions. Once those patients to receive the full advancement or two-jaw surgery, OGS, if you perform the pharyngeal flap, and how come of their development of their maybe the speech problems, or yeah, in your experience sharing. Thank you.
When we started doing the osteotomies for those patients who have received pharyngeal flap, there was an initial reluctance that we might have difficulty to do the Lefort 1 osteotomy. Having said that, while the procedure of the Lefort 1 osteotomy may have some difficulty in mobilizing the segment, fortunately the outcome did not significantly differ. In other words, in our own cohort of patients that we have been following up properly and with all relevant data, we've noticed that patients who've got resolution of VPI at an early age did not deteriorate after surgery. However, those who did not have VPI may have VPI development after Lefort surgery. They were not the patients who received VPI correction, mind you. And if there is a moderate degree of VPI before orthognathic surgery, those patients have couple of patients have changed the grade. So from moderate, they have gone to severe. From in the entire cohort, and this is not linked to the quantum of movement as well, which means it is not directly linked to how far away we are moving the maxilla, how much we are advancing. Irrespective of the quantum of maxillary advancement, there is some change in the VP status from moderate to severe. Those patients who've received VPI correction in their adolescence between the 6 to 12 years of age group, they did not have any impact after the Lefort 1 osteotomy, including the ones with pharyngeal flap.
Okay, got it. And the next question from Professor Fayyaz is, once your patient developed obstructive sleep apnea after the pharyngeal flap, do you have any guideline to help the patient to breathe normally?
Yeah. So again, this is experience of two separate cases. One is a case where a pharyngeal flap was done elsewhere, and it was done when he was 12 years of age. And this patient developed sleep apnea, but more than sleep apnea, he was identified as an airway resistance syndrome, wherein while he's awake as well, he's not able to breathe properly. And in this patient, coincidentally, debulking or detaching the pharyngeal flap was advised, with the caveat that his speech might deteriorate, and his speech did not deteriorate as much. So that is one cohort, one patient. The other patient, a trial of CPAP was started, and so the patient was able to tolerate with a low pressure CPAP therapy, and is probably continuing the same. We don't know. But that's the only experience with patients with sleep apnea and obstruct. And I think the other thing that we have also noticed is that because sleep apnea is so underdiagnosed, until and unless we kind of ask all our patients to either go through the questionnaire or kind of go through the screening of sleep apnea for those patients who have received pharyngeal flaps, it is going to be hard.
Great. And the next question is about your post-operative physiotherapy. Yeah, so after the surgery, with physiotherapy and without physiotherapy, do you have a different result in your long-term follow-up? Yes,
I will
please.
Aparna answer this question with regards to our speech therapy protocols for patients with BPD.
Yeah, so speech therapy, so in some of the cases, as I mentioned before, we do therapy even before we diagnose or we do an imaging for BPD. So we might be taking them up early so that we prevent some of the errors which could be secondary to the vidopharyngeal dysfunction. Even when the patient is not ready for a BPD assessment, we still be correcting the speech errors. Post-operative speech therapy usually starts in a month's time, and it would continue. It is a little long-driven process. Most of the time when kids have already learned the pattern, it is like their language. It's quite phonological in nature. That's their brain is so adapted on using those patterns, and they rehearsed it for many years. So they will have to continue on this training for a little longer time, so that they move on from abnormal resonance. Even the resonance, they can be a vilopharyngeal mislearning. Even after the VPD is corrected, completely corrected, they still prefer to use a nasal tone. So this has to continue. So in younger kids, the prognosis is really good. We may be able to discharge them with a normal speech, even if their speech is severely affected. Older patients, it depends on their motivation. So we check for the motivation as well as of now. So to see if they are a candidate for therapy. And if they're really motivated in correcting, they try really hard. But as an adult, unlearning the pattern is quite hard.
Okay, thank you, Dr. Habermas. And the final questions for Dipesh is that primary parodonticity you have performed for lost patients, and all those patients receive immediately speech therapist. And once the patient developed velopharyngeal dysfunction, do you see any differences in the scarring when you perform the surgery? Yeah.
Again, because scarring is such a subjective measure, it would be difficult to identify if they are the patients who've received speech therapy or not. But I think it is safe to say those patients who are on our radar and on routine follow-up, wherein they receive timely speech interventions, the VP status, if present, is picked up early and resolved early. They are the ones who respond the best to cleft palate repair, and that is something that we have noticed, and I think is of course well established, because that is how it should be. The VP correction should be at a correct age. I also see one other question by Prof. Fayaz about our preference of pharyngoplasty. We use the suspension pharyngeal flap at always. We never do the sphincter pharyngoplasty. Our preference is to do the suspension pharyngoplasty alone.
That's great. Any panelists or our professors want to give some of your special comment for those question? Professor Fayaz, Professor O, Professor Hikosaka, Professor Lo. Professor Fayaz, yes, please.
Yeah, we are analyzing the data of pharyngeal flap done at our hospital, and in the last 10 or 11 years, we have done more than 2,000 pharyngeal flaps. So that's why we are now organize our data. We are going to classify the short palate, and on the basis of that classification, we will also give an algorithm where we will share some modification in raising the pharyngeal flap and some modification in splitting the posterior under the soft palate to allow the pharyngeal flap to come in. So my apprehension is, I was approached by one of our friends from Guatemala. She is an orthodontist, and she sent me pictures of a patient who developed complete sleep apnea, complete obstruction. The patient could not breathe through the nose. So although I have not seen any patient in our practice. So she asked me what should be done. So I'm just sharing an idea with all my friends. So although I have not done it, so I told her that you can put a catheter through the nose, which will touch the palate, and that area should be marked on both sides, and you can excise part of the tissue from there. Then you can keep a tube or trumpet for 2 to 3 weeks, and patient should be able to breathe even after there is complete attachment of the palate to the posterior pharyngeal wall. I would like to have any comments by friends from this panel or the presenter.
Okay.
Yeah, Professor O.
Yeah. Okay. Thank you.
Yes.
Okay. So if the patient, one day I was very surprised that the patient has a cleft lip and also cleft palate, and the parent said to me that I don't care about the scar. the cleft lip scar, but never make my baby with a BPD. So sometimes as a cleft surgeon, we are more concerned about the scar of the lip, but sometimes or many times the parents, the standpoint is sometimes different with our surgeon's standpoint that so I think that we should more concern about more care about the VPD. So that is my final comment.
Thank you, Professor O. Professor Hikosaka, you have a final pearls. Thank you.
Well, Dr. Dipesh Rao, thank you very much for your presentation. It's clear cut and I learned so much from you. Thank you very much. And I totally agree with Dr. O that speech has so much for these patients because speech is the gateway to the psychosocial interaction with the others. So I totally agree with Dr. O. We should be more careful and concerned about the patient's speech. Thank you.
Thank you, Professor Hikosaka. And the last is Professor Low. Yeah, Professor Low, please. Thank you.
Well, when we have a patient with VPI, and we choose procedure if the closure ratio is like criteria 0.7 or higher, then we do phalangeal flap. And I think I'm sorry, we do double opposing Z plus C. And I feel that this procedure is a good procedure in terms of resolution of the hypernasality and also do not feel uncomfortable. And then if we do phalangeal flap for patient, and if patient feel airway obstruction, and there was occasionally some patient who complain obstructed airway, then I would ask patient which one is more important to you. If airway is more important, and I will enlarge the portal in order to have a good airway. If the patient very uncommon patient will complain that I want a better speech, then if she does not care about the airway, then I would continue to do more obstructive type of phalangeal flap. So this is my philosophy in choosing the procedure. And I think the most important is to discuss with the patient, with the parents, which one do you prefer? Because it's like a balance on both sides that is difficult. Sometimes it's difficult to obtain both airway and competent speech. Thank you.
Thank you, Professor Low. Finally, I would like to invite all our audience of ICC today to show your face and your attendance and your participations are so encouragement for all the speakers and our valuable panelists. Especially today, we have lots of professors from Korea, from Pakistan, from Japan, and Professor Low as well. Thank you for Dipesh Field non-reserved to share your difficult cases with your speech therapist, Professor Apana. Thank you very much for your coming. I would like to count to 3 and please show me your big smile. Yeah, we just finished our Happy Lunar New Year vacation. We have to go to work, so I'm a little bit depressed now. So please give me a smile. Thank you very much. And I'll count to 3. 1, 2, cheese. Thank you very much. And I would like to announce our next ICC webinar is 1 week later. And the next coming Sunday, the topic is the computer-assisted internal distraction osteogenesis in managing cleft-related maxillohypoplasia, and be presented by Professor Li Jintao from Sichuan University from China. he would like to show some difficult cases as well, how to do the DO to improve the mid-phase hypoplasia. Thank you again, Dipesh. Would you like to say something to all our audience?
Thank
Your
you.
final comment? Yes.
Thank you, everyone, for taking time out on a Sunday. Like I mentioned right in the beginning, I have learned so much from this webinar series myself, and it is a real great honor to be participating. Look forward to more such great job that you all are doing. Thank you so much for putting up this and doing it 122, right? Wow, what an amazing feat.
Thank you. And I believe we will see each other in the near coming future. Korea, Japan, Pakistan, India, everywhere. Okay. Have a good day. Have a good night. Thank you very much. See you. Bye-bye.
Good night.
Bye-bye. Good night. Thank you, Professor O. Thank you, Professor Hikosaka. Arigato. Thank you, Fayaz, Professor. Okay. Thank you, Dipesh, and thank you, Apana. Thank you very much. Good evening.